Hey guys.
We will come to order. I'm Dr. Ken Lippincott. We have Dr. Rod Givens here and Dr. Randy Roth on Zoom. And uh, the first the first order of business is a Zoom appearance by Dr. Simeon Kwan. Do we have Dr. Kwan on the screen?
Dr. Kwan, can you hear us?
Yes, I can hear you.
Okay.
And I see you on the screen.
Yeah, we can see you now. Um, uh, Good afternoon, Dr. Kwan.
Hello.
So, could you just please tell us in your own words what you're requesting us to do for you today?
Yeah, so I'm a palliative care physician. I work for a national organization called Carillon. We practice in almost all 50 states. Um, we don't have a physician who resides in Mississippi, but we have two nurse practitioners in Louisiana who are available to provide virtual care and when needed travel into Mississippi and for in-home visits. We only practice in patients' homes and do about 50% virtual, 50% in person. So we're requesting an extended mileage exception to allow us to collaborate with each other. I'm a family medicine physician with my background training in palliative care as well, fellowship certified. Um, we would also fulfill the requirements of monthly chart reviews and quality improvement program, quarterly in-person meetings, and all their documentation. But we are seeing if we could have an exception to that 75 mile rule.
And are you board certified, Dr. Kwan?
Yes.
And what are you certified in?
I'm board certified in family medicine, and I have a certificate of added CAQ in palliative care under family medicine.
And could you give us an idea about the general nature of your have you how many states are you practicing in?
Uh, well, our organization is nationwide, but I do a lot of administrative roles for us, and I practice in many states. Kind of depends virtually.
And have you worked with these NPs that you're requesting the extended mileage for?
Yes.
And they're located in Slidell, is that correct?
No, they're in Louisiana. They're both in New Orleans area.
Slidell, Louisiana.
Yeah.
And could you give us an idea about the nature of the practice, please?
Yeah, so our patients are referred to us by their payers, their insurers, because they're mostly frail, geriatric folks in and out of the hospital with a lot of chronic conditions. So we provide palliative care to them in the home, try to keep them as home as comfortable as long as possible, take care of their symptoms, a lot of goals of care planning, advanced care planning discussions with them. And when appropriate, some of them transition to hospice care if they continue to get sicker. Otherwise, we continue to take care of them in their home.
Do you continue their care if they're transitioned to hospice?
No, then the hospice agency takes care of all of their care.
Okay.
So,
Okay.
sorry, okay, I'm Dr. Givens. So turn your mic on, please. There we go. I'm on now.
Yeah.
So your company or your affiliation would be as home health, is that correct?
No home, not really home health, because home health seems to be more nursing driven. We are actual, physicians and advanced practice providers prescribing, managing the care of the patients. But we just happen to practice in the home only.
Okay. Maybe elaborate a little bit more. That it's just a model I'm not familiar with, so I'm just trying to understand. Initially, I was thinking, you know, hospice care or home care, but explain that model to me.
So our patients are a little bit healthier than hospice. They're not quite in their last 6 months of life, but they might be in their last several years of life, usually combinations of multiple illnesses, many medications, in and out of the hospital, very frail. So we provide an extra layer of support where they're still seeing their primary care doctor, but we kind of fill in the gaps. We see them in their homes, especially because some of them become more and more homebound over time. And then we manage their symptoms, anything that could be bothering them, dyspnea, delirium. And then also we do a lot of advanced care planning with them, talking to them about their goals and wishes as they decline, and what they want their final trajectory of their lives to be. And then when appropriate, eventually we might transition them to hospice if they keep declining. But we're sort of in that gap between before they're not quite in their last 6 months of life. It's a little bit pre-hospice, just palliative care. But we're not exactly providing primary care either. We're more of an extra layer of support between them.
Got it. Okay. All right. Thank you.
So, Dr. Kwan, this care takes place where does this care take place? In the patient's homes
Mhm. In their homes.
and is this done by telemedicine technology or in person or what?
Uh, Currently, since we can't practice in Mississippi other than physicians until we have this, approved, everything is done telemedicine. But in other states where we have our full practice model, we're about 70% in person, and then about 30% we layer in the virtual care.
So, how does the in-person care take place? Who actually sees the patients?
Well, these would be the two nurse practitioners that I'm trying to get an exception for. One is named Holly, and the other name is Catherine. Mostly they would be doing virtual care, but we would like the ability to be able to go into Mississippi sometimes and see them because they kind of live near the border.
Yes. So when they're doing this virtual care, they're accessing the patients via telephones or computers in the home or what?
We're on Epic, the EMR platform. So Epic has its own, virtual care type of appointments it can do where you do the whole visit through Epic.
And how exactly does that work?
Well, usually the physician or the clinician opens up the computer and they start the visit on Epic, click start visit, and then usually a link gets sent to the patients or the family members who are taking her with them. And then from there, they can open it up on their computer or their phone, and then it'll just kind of provides a virtual platform for us to communicate on.
So how would they do the physical exam?
Physical exam is limited in virtual capabilities, but we can still talk to patients. We can still do psychiatric exams. We can do neurologic exams. We can assess their overall status. But yes, we can't do a complete physical exam virtually. Can't listen to their heart, can't listen to the lungs, but we can still assess their overall situation and look at their, even their skin and assess kind of the overall appearance of the home as well.
So in this um, mostly virtual care, there's not a healthcare provider there.
No, they're usually with their family members, or sometimes by themselves, but depending on how much technology they feel comfortable with and how sick they are. The sicker folks are, the more and more family there is nearby them, or even caregivers.
Okay. And now the document I have here is that you're requesting an exception to the 2080 in-state practice requirement, but you mentioned the 75-mile rule. But are you requesting for exceptions to both? Are you requesting an exception to the? Are you familiar with the 2080 in-state practice requirement?
Uh, yeah, I guess I'm requesting exception to the 80/20 rule.
Excuse me, Dr. Kwan, what is your proximity to these nurse practitioners?
I'm in Houston.
So you're not within 75 miles. So
No.
you need exceptions to both the 75-mile rule and the 2080 rule.
Yes.
You're
Okay.
talking about Houston, Texas, not Houston, Mississippi, right?
No, Texas, Houston, Texas.
Thank you.
Dr. Kwan, you've given us a couple of different percentages on how often y'all physically see the patient. When you first presented, you said 50% of the time, and then later you said 30% of the time. Can you clarify for me how you expect two nurse practitioners in Louisiana to see patients in North Mississippi 30% of the time?
Well, I was giving you national numbers. I think in this practice model, sorry, we practice differently in each sort of city we're in. Usually, if we have a very well saturated area, we can practice about 70-30. This, I think, is primarily going to be virtual, probably 95 to 5, only really going into Mississippi if they really need to.
So you're in Houston. Have you ever met these two nurse practitioners that are in Louisiana?
Yeah,
Physically, in person, met them?
yeah.
Okay.
I actually go there quarterly and I see them. And we
Okay.
do patient ride
They're
alongs and
already,
such.
you're already collaborating with them for their practice in
Mhm.
Louisiana.
Yes.
What percentage of time do they go into the house in Louisiana?
So there, I think it's a little bit more of that blend of what I was saying earlier. I think they're around 70% in person, 30% virtual.
Thank you.
Dr. Roth, do you have any questions for Dr. Kwan?
Yeah, I have one or two. Dr. Kwan, Randy Roth, I'm an internal medicine physician in Pascagoula, Mississippi. How are these patients allotted and assigned to you? How do you get this group of patients? Is it through the carriers or through referrals? How do they land on your lap?
Yeah, so we have contracts with these Medicare Advantage mostly companies, big payers in Mississippi or wherever we are. We go through the sickest patients, about the top 1%, top 0.5% of the spend, people who are high risk for them, and they refer these patients to us directly, and then we reach out to them.
So do you bill the Medicare Advantage plan, or do you bill the patient for a professional fee and CPT?
No, we only bill the payers directly on a per member per month type of relationship. So we don't bill any of the patients directly.
Okay, thank you.
And I have a couple of more questions, if I may. Do these nurse practitioners make a diagnosis, an assessment, and a plan?
Yes,
Do they write prescriptions?
yes.
Do they change the medications?
That would be case by case, depending on what it is.
So,
You usually not change the whole plan. They'd probably consult with, PCPs if it's something egregious, but if it might be some acute infection, they can prescribe.
so in your model, they still see the primary care physician in the state of Mississippi. And
Yes.
you're representing to us here today that they would not change the medications that are prescribed by that primary care physician.
It depends what medication, but the most common circumstance is if there's a problem with, let's say, a blood pressure medication, then we will call the PCP and we'll say, hey, it looks like some of the blood pressures in the home are a little bit low. They're on 3 medicines. Have you considered maybe dropping, taking one off? We don't generally adjust the chronic medications, but we will prescribe acutely.
Thank you.
So, is there anyone else here in the meeting with you, Dr. Kwan, that would like to present any additional information?
Nope, it's just myself.
Okay. Any other questions or discussion?
I have no further questions.
I think we're ready to consider a motion, maybe a motion to enter into executive session.
Yeah, make a motion. We enter executive.
Closed session.
I'm sorry, close the session to consider or determine whether to go into executive session.
Second.
All in favor, say aye.
Aye.
Aye. The ayes have it. So we're in,
Motion to closed.
the meeting is closed.
Make a motion to go into executive. You want me to handle it for you?
You're the lawyer.
Okay, we'll hear a motion to go into executive session to consider matters that may, an application.
Oh.
Do I have a motion?
A motion?
Do I have a second?
Second.
Any discussion? All in favor?
Aye.
Aye.
Board is now in closed executive session and will return after deliberations.
Thank you.
Okay, thank you.
Hey, Ken.
Hey, Randy,
All right. Everything's muted. I'm here.
can you hear us?
Yes, sir. Yes, loud and
Okay,
clear.
yeah, we're in the, we're about to say that right now. We're back in the, we're back here at the dining table
Okay.
and,
I don't think you're muted.
and, anyway, I'll entertain a motion.
Okay.
Not, I mean, not your volume.
Yes, my microphone is
Hello?
muted in the executive